Good morning, everyone. It gives me great pleasure to introduce Dr. Trevor Shaddox for today's presentation on learning about BFRBs using web-based tools. Dr. Shaddox was born and raised in Orange County and did his undergrad at Stanford, followed by a master's in biomedical informatics at Stanford. He really liked being in school, I guess, so he came to UCLA where he was in the MSTP program, finishing with a PhD in biomathematics, not your usual path for somebody in psychiatry. And he really wanted to continue doing training, so he was an adult resident here, and now he is in the second year of the Child Fellowship, and he'll be completing in June. When I was talking to Dr. Shaddox about the introduction, he said, I've been here for 13 years. People should know me by now. And I assume you all do, so I'm not going to take any more time. But really, really excited to listen to this presentation. So Trevor, go ahead.
All right. Thank you so much, Dr. Passantini. It's really been a pleasure to be able to get to work on these projects with you and to pick your brain as I've gone through it. So I'm going to go ahead and start the screen share. As I was joking earlier, I feel like I should know everything about Zoom at this point, but as soon as I say that, that's when I accidentally hang up on a patient. So we're going to try this, and if there are issues or if there's a problem, just send the chat our way and we will go from there. Awesome. Okay. So yes, I have been here for a really long time. And what I hope that you're all able to take away from something like that is that you know me, and you know that hopefully you feel comfortable being able to come up to me and talk to me. And the reason I'm starting with that is because I want this presentation to be the beginning of a dialogue. When I share slides like this and when I share projects like this, one of the great joys for me is being able to pick the brains and the wealth of information of all those who are surrounding me here at UCLA and who've kind of guided and advised me through this process. And that's all of you who are on this Zoom meeting. And so as we talk about this, as we talk about the disease process, some of the methods that I use in this space and how we kind of think together about what it means to look at these results, I hope that I can extend all of you an invitation to approach me and talk to me about them and chew on these things with me. Because there are many philosophical and kind of meaningful clinical ways that we can think about it. And I think we all become better when we chew on them together. Okay, let's go ahead and get started. Today, we're going to be learning about BFRBs, specifically through online stuff. I do not have any disclosures. Sorry, let me re-say that. I sadly don't have any disclosures. I'm actively seeking financial conflicts of interest. If any of you have recommendations for financial conflicts of interest, I am open-eared. But in all seriousness, one of the things that we're going to be talking about today is the data source and how we think about a data source that is non-scientifically collected. And so I do want to disclose that the data that I'm using is coming from two websites where there is at least some financial remuneration for their use. And so I hope that can be an underlying topic that permeates all of the discussion today. I want to be upfront in terms of what you should learn and what I hope you learn. And really that comes in two categories. The first category is kind of from a more clinical side of things, which is to think about disease processes, specifically BFRBs. And what I hope that you can take away from this is, why is this worth thinking about? Why are these disease processes worth having in our minds? What do we know about these disease processes so far? And what are some of the open questions in this space? The caveat is that the people who are on this Zoom are much better experts when it comes to BFRBs than I am. I am a novice when it comes to BFRBs. And so I hope, first of all, you feel comfortable, more comfortable asking me questions, knowing that I'm with you in terms of learning about them. And also recognizing that I approach the kind of disease knowledge in this space with a sense of humility, knowing that we are surrounded by people here at UCLA who have published some of the core papers in this field. The other side of things is perhaps where I add the most value, which is thinking about how do we quantify and model and wrap our head around data that come about from online tools and from continuous and piecewise observations of individual human beings as they go through their life. And this is where I want to challenge you a little bit, push you a little bit in terms of learning how that happens, and also to ask of you to kind of weigh in as we chew on what it means and what we can clinically take away from these kinds of studies. I like to think of it in terms of 3 dimensions, which is feasibility. Is it even possible for us to do some sort of meaningful modeling with non-scientifically collected longitudinal data, both from a clinically useful stance and also from a computationally feasible stance? What are the promises of using these kinds of data? It's often easy to be optimistic and enthusiastic about how these kinds of data might change what we do in our clinical practice, while also questioning what the peril is from using these kinds of data. It's just as it's easy for us to find a sense of promise in this space, it's also not hard to see where some of those limitations might lie and where we should approach them with a sense of circumspection so that we're not overstating what we're learning. That's where my strengths are, and that's where I'm going to push you guys today. But let's focus on the disease process first. So what are body-focused repetitive behaviors? They are kind of unsurprisingly repetitive behaviors that tend to be focused on the body. Whenever my patients have kind of asked me about this, I tend to direct them to the BFRB.org website. And if you go onto the BFRB.org website and the TLC Foundation, and you click on the people who are involved with it, you will undoubtedly see some familiar faces. This is a class of behaviors that encompasses repetitive self-grooming. Classically, these are things like biting and pulling and picking and scraping of skin and hair and various parts of the body. The oldest and wisest of the disease kind of names that exist in this space, at least from our diagnostic perspective, is trick. So I'm going to be referring to this also as pulling throughout this. So trick and pulling are going to be kind of used interchangeably throughout my talk. This is the one that first came into the DSM, at which time it was kind of within the impulse control disorder space. Now it's listed under more obsessive compulsive disorder space. When you think about the epidemiology, you can say that it is prevalent. It has 1% prevalence and kind of like 2 to 4 lifetime prevalence. It's generally seen as being more preponderant within the female population or within folks who are assigned female at birth. And we can think of the onset as being kind of that late latency, early adolescent period of kind of sort of ish 10 years old. One thing we're going to be talking about a lot today are the actual behaviors and the triggers that go into the behaviors and help instigate various phenotypes that emerge. When we think about trichotillomania, you think about like pick location as being a really important part. It tends to be on the things that we place salience on as humans. So face is one, pubic region is another. I want to plant the seed that thinking about triggers in this space is going to be another big theme that emerges over this talk, where from the literature, people identify lots of different triggers for trichotillomania that span each of the categories of what we classically think of as the CBT triad. It's going to be feelings and sensations. It's going to be emotions. It's going to be thoughts. And the reason I'm planting that seed is because if we think about these disease processes in that way, it does help to inform what we might be doing from a modeling perspective. The neural mechanisms here are a little more opaque than what we might see in some of our known disease processes. It's kind of sort of OCD-ish. Maybe there's a little less frontal activity. Maybe there's a little bit more parietal activity. But if we know some things, but not a whole ton about trichotillomania, we know slightly less about skin picking disorder. And this is the second of the BFRBs that enter into our diagnostic nomenclature, coming in with DSM-5, also under kind of that other obsessive compulsive umbrella. The epidemiology and kind of the literature that's describing how this exists within the population is also a little bit hazier. We don't see some of the clarity that we find within the trichotillomania literature, where it's kind of like 1 to 10%-ish of people who have something that would be classified as disordered. Considerably higher if you look at the phenotype a little bit more broadly, including people who are not like strictly disordered. I can tell from my experience going to like science conferences, it's higher than 60% of people who present at scientific conferences who have like significant skin picking on their cuticles. Like it's just like probably, I would have guessed it's probably more like 80% of like PIs have some sort of skin picking as part of their like presentation. Maybe there's a wider onset distribution. Maybe it's kind of a little bit higher in the age group, but the data really aren't clear in this space. Also, the gender differences are a little bit less clearly defined than they are in trichotillomania. But once again, when we come back to the phenotype, we see the kind of scratching and pinching as you might expect, but the triggers remain the same. You can still see the triggers as representative of our CBT triad of thinking about things in terms of thoughts, feelings, and actions, where sensory, emotional, and cognitive effects are a big part of what drives the phenotype and the behavior itself. It's important for us to think about standard of care, since the online tools we're going to be looking at today are related to how you care for the disease. And for both of the phenotypes that we have kind of like nice diagnostic categories for, trick and for skin picking disorder, the one thing that emerges from the literature is that it's therapy that's really forming the core pillar of how you would be approaching someone with these disease processes. And unsurprisingly, it tends to be very CBT and behaviorally focused type therapy, including habit reversal therapy, CBT, and kind of bits and pieces of ACT and DBT sprinkled on top above the frosting that is kind of the rest of the therapeutic stance. Medications are a little less consistent for both of them and probably are a little bit less effective overall in terms of the big picture of things. But really what I want you to see is that if you want to treat this stuff, it has to have a therapy component. And if you want to treat this stuff well with a therapy component, it has to have a pretty direct behavioral CBT element to it. And this is where we reach kind of an orthogonal theme that's going on at the same time as these disease processes are emerging, which is scalable therapy. You know, people kind of very obviously recognize there are lots of different mental health crises going on simultaneously within kind of our population here in the United States and also globally, recognizing that we're kind of gradually swamping the number of individual clinicians who are available to treat people in meaningful and kind of effective ways. And so the question arises is how can you be scalable in terms of approaching and addressing that kind of need? So starting in the mid-2000s, as people are still kind of hung over from the dot-com craze and recognizing the impact of tools that might be online, you get an emergence of a lot of CBT-informed online resources. And the goal for these is pretty honorable, and you can see where folks are coming from in terms of being able to move in this direction, where you want to provide skills. You want to provide skills and perhaps an interactive experience, and you want to have skills and an interactive experience that's evidence-based and kind of data-driven in a way that is accessible broadly. And the benefits to this are that it tends to be more private. You don't have to go to someone's office. You don't have to kind of confront the shame of talking to someone about this directly. It tends to be cheaper, relatively speaking, on a per unit scale. And it tends to open up avenues in terms of ease of access for some evidence-based tools. When, of course, people have looked at this and they ask questions like, is this even worth doing? The graph that I'm stealing here is from a systematic review looking specifically at like scalable online type therapies outside of the BFRB process. So specifically for MDD, this tends to be one of the higher quality systematic reviews that's been done on scalable online therapy. And as you can imagine, since it's been published, you can guess that it did have an effect. And as you can imagine from what we're seeing here in our graph, it kind of favors the fact that something gets better in this space. Okay, so what do we know right now? We know we've talked about the disease processes. We've thought a little bit about what are the big types of picking and pulling that happen within the BFRB category. We know that the standard of care for BFRBs is kind of CBT-informed, evidence-based, behaviorally focused therapy that is relatively kind of concrete in how it's delivered. And at the same time, we're learning right now that there is such a thing as scalable therapy, and this scalable therapy has some sense of evidence in terms of its efficacy. So you can all guess where I'm going with this next, which is thinking about scalable therapy for BFRBs. And this is where the data sources enter into our history. So stoppulling.com and stoppicking.com both came onto the scene in the early 2000s, mid 2000s, where it was designed to be able to provide kind of a targeted therapy where folks would log every urge that they experienced, or they would log events that they perceived to happen, that you can also log when there isn't an urge. And what you would do is, for the low fee of $29.99 a month, have access to a protocol that gave you a sense of assessment, where you would go for a couple of weeks without an intervention, so that the program would learn a little bit about what your experiences were. Then there would be interventions proposed, specifically coping skills and therapy tools using a CBT framework. And then there would be a sense of maintaining that type of progress, if any, happened. And that trajectory, that algorithm for treating folks using these tools is displayed very clearly on their websites. It's the core and crux of what they are trying to present as their deliverable product. So people study it, as you might expect, and there's a lot of evidence to suggest that self-help techniques within the BFRB space tend to be pretty effective. Unsurprising to all of you, once the data came out, people studied it. So in 2006 and 2007, there were both a couple of papers that looked at the data from these two websites, where they have some metric of whether or not people are picking or pulling at the same rate. And since you know I'm talking about published products, you can kind of imagine that, of course, they're going to have some demonstration that the impact of what their product is positive, that they have some measure of decreased behavior, of decreased pathology, of increased comfort as a result of using these two websites, and as a result of kind of engaging with the tools that are presented on these websites. The sample sizes, though, are relatively small, and I will point out that these are also just from kind of a couple of years of data. So now we're looking in the future. So these websites have been around since 2003, so the early 2000s. So we're thinking that these folks who have been in here, who have come into these websites, who have left these websites, have been engaging with these kinds of skilled tools for a relatively long period of time. And the question that gets presented to us as a community, to me as a researcher, to you as my research colleagues as we're talking about this, is what can we learn from these data? And I very specifically frame it as, can we learn from these data, rather than what can we learn from these data? Because it's important for us to recognize together that that we need to ask before we do something like this, and we kind of approach these data and decide to learn from them. We need to ask ourselves, and we need to ask the data, whether or not there's enough information content in there, and whether there's enough kind of clinical pearls that we're going to be able to get at the end of the day to justify this kind of observation. Again, thinking about promise and peril. When we think about promise for these data, that part seems accessible and really enticing. there is a wealth of capture in this data set regarding time in a way that is almost completely inaccessible to scientifically collected data sets. Time is probably the richest thing we have in this data set. The most density of duration in the data set is around half a year, which is to say that if you look at how long people spend using the tools, logging in, so this is not just like how long they're registered for the website, this is like how long they're actively using it. It's a long time. But what I would argue is even a richer source or a richer dimension of time is to look at how much people have been using this website over now 2 decades. There's some differences in terms of pulling and picking, sure. Maybe if you squint really hard, you can see a bump that happens around COVID, which is kind of interesting. But the big thing I want you to see from these 2 graphs is that time is the wealth that we're going to be hoping to extract from these data. Space is also not too bad. We see that we collect people pretty broadly across the United States. We are kind of tied predominantly to major metropolitan areas, which is not super surprising. There doesn't seem to be like a major divergence in terms of pulling and picking across all these different things. And that's where a lot of our optimism ends when looking at these data. Specifically, as we turn to look at the demographic data, I hope that you can all share with me a sense of disappointment at the breadth of who we are capturing in these data. This is a population that is massively, overwhelmingly white. And then just a quick caveat, I am reporting the categories of race and ethnicity with fidelity to how they are coded within the data set. These are design decisions that I was not a part of, and these are design decisions that happened back in 2003. And so I want to be faithful in terms of representing how those are coded in the data set as we analyze them. To give you a gut check of how like not representative this data set is, this is less racially diverse than Brentwood. So if you go to Brentwood right now and you sample people at random, you will have a more diverse data set than what we are looking at here, which is something. And I think as we look at these data sets, we look at what we learn from these data sets, we look at how we take these data sets and metabolize them into something that's clinically useful, I think it's worth all of us looking at this demographic failure and significantly weighing how much that impacts what we're able to take away from it. And if we as a community, as a population, decide that this is kind of an existential limitation to these data sets, I'm willing to have that conversation. We're going to push through, but I don't want to minimize like the poverty of our ability to extrapolate from a demographic data set that is so skewed in terms of its representation. If we decide to push forward, we can still move forward with something that resembles a sanity check. And there are a few things that we kind of suspect that we know from the data set, which is when do people start to have symptoms, and you see a peak around the time when you would expect. You see weirdly a later peak that happens. Not totally sure what to make of that. That's really not represented in the data set. And that's not really represented in the literature. We also know from previous studies that picking and pulling behavior tends to happen later in the day rather than earlier in the day. And so you unsurprisingly see that replicated in terms of when people are logging on. Okay, so that now we're at the point where we're going to say, let's say we've decided together that we want to learn from these data sets. How are we going to do it? Well, historically, the way that people model stuff within therapy is you kind of take the post and pre-study design where you say, things are bad, and then you do some magic, and then things are better. Sometimes folks do something more sophisticated where there's like multi-level modeling where you consider the role of the therapist in it, you consider the role of the patient in it, you look like individual patient like demographic factors and kind of measures of rapport that happen. But it also tends to be relatively like pre and post. People who do stochastic modeling in this space tend to not be from our community. They tend to not be from psychiatry and psychology. They tend to not be from primarily therapy-oriented subspecialties, but rather they actually tend to be from anthropology. And if you go digging in the literature, you'll see that there are some stochastic models of how humans interact with each other that exist within anthropology. Okay, this is one of my favorite things to talk about. If any of you on this call have had the misfortune of being stuck with me in an elevator that's not working, you probably inevitably found yourself talking to me about this and wondering why the hell I'm so passionate about it. I love talking about the difference between machine learning and stochastic modeling, between the computer science people and the statistics and math people. I used to say this is kind of like a religious preference, but I've realized that tends to have some pretty strong categorical connotations to it, and I really do see this more as a spectrum. So now I'm going to be talking about it more as like your sexual orientation or like your sexual preferences. Some people really like the computer science stuff. That's really what gets them going. Some people, like me, really like the stats and mathy side of things. The way that I reflect on what the difference is between these two disciplines is the computer science people think about partitioning data. How do we take a space where you have some data set that you care about, and how do you split it up so that you can chunk people or data points into various categories? How do you categorize things? The measure of success in this space is prediction. Like if you do it for data set A and you apply it for data set B, you get your grade on how well you did based on data set B. It tends to be data driven. So you're saying, we have this data, we're not going to make any assumptions about it. We're going to say, split it up. I come from more of the other side, so that tends to be the bioinformatics side. So I've done some of that stuff. I kind of cut my teeth in that discipline. But more recently, I have come to be more attuned to the stats and math side of things, where the way that people approach it within this space is you think about a model first, where you say, I have some idea of how these data have been created, of how the process happens. And then you ask yourself, how can we take the data and apply them to this model, and then ask ourselves, how well do they fit? The benefit of this is that you have the understanding of what's going on in the disease process that can percolate through the data and allows you to have some sense of a toehold in terms of what the data are telling you. Rather than learning via prediction, you kind of learn via inference in this space. What would we want? Well, what we wouldn't want is the two things on the right. Those are not things that you want. Those are things that you don't want. If you show that to anyone in any discipline, and it's a big mess of a bunch of arrows and slides and equations of various things that determine how like your model looks, you're going to lose everyone. They're going to glaze over. They're not going to listen to you anymore, and they're certainly not going to know how to use the results. What I think we need when we're going to be approaching some kind of modeling problem like this is you're going to need accuracy, which is to say you want the model to be informed by what we know. And what I know we know is that the CBT triad is really important to BFRBs. You also want it to be informed by your demographic data. And you also want it to have some sense of longitudinal connection. The reality is that as clinicians, all of us think about disease processes in terms of trajectories. And what you're going to want to do is have a model that can be extended to a trajectory if you want to have real clinical interpretation. But in a sense, being accurate is not enough. You also want it to be bite-sized. You also want it to be sufficiently simple that you can explain it to people. And you want it to not be too wonky and out there. If you use methods that are really effective at splitting up your data, but nobody knows what the hell you're doing in them, it's going to be really hard for clinicians to take those kind of results and reduce them to a clinically useful knowledge set. I would argue that the recent history of bioinformatics and machine learning and data science and big data and all the different funny terms that we use for it within psychiatry has been one of failure. Like, we have not found, there have not been big studies using those methods that have meaningfully moved a lot of clinical work. And part of the reason for those kinds of failures is that the models are not really replicatable in terms of, are not really reflective of what we understand within the disease process. And so they're hard to use clinically, and or the models themselves are too complex to really be bite-sized, or the kinds of analysis that go into it are too kind of esoteric to really be appreciated at the clinical level. And I hope that we can share a formulation that what matters is that any results that we get from this are clinically interpretable, and we can actually use them with patients. Okay, so let's move forward with how we're thinking about this right now, where we say, okay, it's well replicated in the literature that the CBT stuff are triggers and are kind of intimately connected with how BFRBs arise. So we've got thoughts, we've got feelings, we've got actions. The nice thing about this data set is that it's coded to reflect that. It's coded to reflect thoughts, feelings, and actions, but specifically it's coded to reflect time in those thoughts, feelings, and actions, where you have antecedent stuff, you have a behavior that's coded, and you have consequences. So for every logged episode, the people who are using the website are asked, how did you feel before, what did you do? How did you feel before you did it? And what happened afterwards? And the what happened afterwards is going to be really important as we look at the data today. But this graph, this model that we have in front of us, becomes the core of how we can begin to think about these data. We can think about antecedent thoughts, feelings. We can think about behavior, and we can think about consequences. But the data are coded as single snapshot events. What we can do together, which is clever, is to combine them. So rather than thinking about single snapshots, we're going to think about pairs of snapshots, or specifically moving from one snapshot to the next snapshot, recognizing that we are capturing this event and then next event, which has the intensity of the prior behavior. It has reinforcement that happens after the prior behavior, along with the immediate antecedent thoughts and feelings. Because the data set also has the skills and the therapeutic tools that are integrated and put into the data set, you also have therapeutic interventions that we're capturing. The trick here is time. And we can measure the time between one of these snapshots to the next. And we can think about how these features impact the amount of time between logged events. What we do is we can build this together, looking at a baseline that underlies everything, from snapshots to pairs of snapshots to a chain of pairs of snapshots. And what we realize that we've built is a trajectory for each patient. By combining these individual pairs of snapshots. And this chain gets mutated along the route with therapeutic interventions, and also reflects a similar baseline characteristic. What I hope we can argue is that this captures some sense of our clinical intuition. And we open ourselves to learning with pretty canonical tools. The fact that we build the chain for each patient based on a baseline and the time to event for various kind of pathologies. Note that this patient here, it looks like they are getting worse. The time between events is shortening. Whereas for this patient, they look like they're getting better. Time between events is lengthening. By writing our model in this way, by constructing it that way, I hope we can share that that captures how we might talk about one of these patients in our clinics. Now, I'm gonna really mess with like the CBT-ness of this talk by saying that we're gonna steal from Bion, actually, and I'm gonna quote Bion with this, which is, I'm gonna use the Bion quote that we should approach a therapeutic and kind of a therapeutic moment without thought or without memory or desire. And the reason I'm stealing from that right now is that's essentially the Markovian assumption. What we are going to make is a Markovian assumption about each of these snapshots, which is to say that individual like jump is going to just depend on where you were before. So this jump right here depends on where you are right here. And it does not depend on all the things that happened before that. When we make that assumption, which is worth questioning, we can talk about that, we see a bunch of time to event models. We see a bunch of survival models. And as soon as we see that we can decompose our chain trajectory into a sequence of time to event models, we realize we can draw inference on our model using something that's very well known within our literature, which is a Cox proportional hazards model. So now at this point, what we have is we have a model that seems somewhat reflective of what our intuition might be. And we have a way of drawing inference on it that's not too wild and crazy. It's something that resembles canonical. I'm guessing most people are going to fall asleep when you start talking about like drawing inference and kind of putting penalties on things. What I would want you to really know is when you look at a slide like this is you're doing a lot of hypothesis testing whenever you're doing stuff that has this many dimensions. And if you're not being wise in how you're accounting for it, you're going to draw kind of erroneous conclusions. The way that we're circumspect in how we approach it is through sparsity, whereas we're going to enforce sparsity. For everything that we count as being meaningful or weighty in terms of being a part of our model, we're going to tax it. So for every variable that we include, we're going to put a little tax on that variable, and that's going to enforce sparsity. It's going to enforce a relatively efficient model. If you care enough about this stuff to talk about it more, come talk to me more. This is the stuff I care about, but usually it's where people start to take their naps. Okay, so how do we do? What do we do? What do we do? Do we get anything? Is anything meaningful or reasonable or useful that comes out of this? Well, you can do a regression and you can fit all the variables and you make one of these like classical slides that I'm contractually obligated to include, which has a bunch of variable names where nothing is legible and you're not really sure how to interpret it. So rather than focusing on individual variable names, I'm actually going to draw your attention to bits and pieces of this that I think are kind of can help guide our intuition in terms of what this means. Okay, so let me orient you. So this is 0. So things above this mean that it makes you go, makes things worse. So it means it makes the amount of time between events longer. So up is bad, down is good. I have the variables chunked together based on what type of CBT element we're capturing here. And there are some themes that I want you to see. The first is in our antecedent thoughts and emotions. This is the stuff that's immediately prior to everything, kind of to the event that we're looking at. What I want you to recognize is that the relative magnitude and weight of the impact of the immediate prior stuff is at least equivalent to the consequences from the prior event. So in other words, when you've had one event and there's been a reinforcement loop that happened there, the impact from that reinforcement loop is at least as strong as the stuff that happened immediately before the event that we're looking at. The reason I'm drawing your attention to that is because this reinforcement part from the prior event is not something that's generally included in statistical analyses of these kinds of methods. It only becomes visible and vulnerable to our analysis when you have a model that like really respects the CBT triad. The other thing that I want you to see from this is that the pink dots and the blue dots kind of sort of look the same, and there are only a few different places, there are only a few places where there's kind of any meaningful difference between picking and pulling. A lot of folks in the literature care about asking about how are trick and skin picking different, and the answer is a lot of the stuff is the same, with the notable exception of race and ethnicity, which comes out here, physical triggers, and play behavior. And then the last thing that I would draw your attention to is this kind of gold star that we're using to signify that we did something good, just like we're in second grade, which is to say that this is the magnitude of whether or not there was a coping skill, which was taught and which was used. And we breathe a big sigh of relief recognizing that it is, in fact, below 0, which is to say that it lengthens the amount of time between events. So it makes people better when they're using a coping skill. So collectively, we all go, okay, the website seems like it's doing something like that matches our intuition of what it would be doing if those skills are actually useful. I prefer to represent these kinds of data in a very graphical sense. I don't think that like coefficient regression variables really capture what's going on. So what I'm going to do is I'm going to show you the same slide that we looked at earlier with the arrows, but the arrows are now scaled based on the impact that you're getting from each of the different factors. And what we see is that the big arrows are reinforcements from the prior event, demographic variables, and our coping skills. While most of the literature would say that it's the immediate prior feelings and thoughts that like lead to the event. What we kind of are hinting at is that maybe it's actually the reinforcement from the prior event. In pulling, it looks kind of sort of the same way. It's the same graph, and you can kind of like flip back and forth between these two and convince yourself that like the arrows change in various directions. It's the same general picture. Okay, so as we're kind of coming to the end of this talk, I want to make sure that we spend time thinking about what we can do to metabolize these results. Methods that are used willy-nilly and kind of for the sake of people like me who like really like the stats and mathy stuff just because they're interesting, don't move the needle in this space. If we do something cool and nobody cares about it, it's useless. Like that's not what we're here to do. That's not what you as clinicians care about. That's not what I as a clinician really care about doing. So I want us to spend time thinking about how do we metabolize results that look like this? And we're torn between greed and fear. Or boy, it sure would be cool if we could make big statements about these kinds of models and these kinds of results and these kinds of data. And at the same time, there are so many different limitations to what these data are able to show. How do we navigate that conflict? Big data has been called lots of different things by lots of different people. It seems like as soon as someone comes up with a new name, another group comes up with an even cooler name. I just know that the least cool way to call it is statistics. If I'm at a party and I tell people that I do like machine learning, everybody's like, ooh, and if I tell people I do statistics, everybody leaves me. But what I have this slide here to do is to note that there is like a difference between like the sexiness of what we're talking about in the topics and like the actual stuff that's come out of it that's meaningfully changed patient lives. And if we're not respectful in recognizing those limitations, if we're not humble in thinking about them, we're doomed to be like everyone else in this space. If you do any sort of big data research and you're not familiar with this paper, I think you should read it right now. Most of the times when people like apply different big data studies to different data sets, you kind of have to recode everything. And there aren't too many places where there are, one, known things that you can find and see whether or not you're able to find them. And two, use methods in a way that's like directly translatable from one data set to another. This paper reflects people who did it right, who took a huge bunch of data, chunked into all these different types of EMRs and Medicaid, Medicare data, and VA data, and they looked at known pairings of effects. So for example, warfarin and bleeding, warfarin and mortality. And they applied the exact same methods across each of the data sets. And as they did, they were able to say, like, what is the effect that we're seeing? And as you can see from this smattering of relative risks, it's all over the place. So for example, warfarin and mortality, if you use different data sets, you get massively different results. And that's really frightening. This is a paper you should hold in the back of your mind to temper any sense of overexcitement that you get from like trying to learn from big data. And this is why we need to stay humble when we're thinking about these kinds of results, even as we're able to be like relatively optimistic about them. There are some clear limitations in terms of like what we're doing here ourselves, specifically that like the diversity of these data sets are poor, they're horrific. And the fact that our data are collected from like a non-random sampling perspective, and they're confounded by the purpose. These are designed to kind of bring in revenue. There's also kind of what I would argue is like the more fun statistical stuff, things like missingness and like non-random missingness and kind of control of confounding that we can think about in this space too. But now that I've scared you, now that I've made you kind of question all of the stuff that would come out of any big data study, I want us to see where we can hang our hat. What of those results that I showed you do you think you can really take to the bank? And well, maybe that's not the right way to think about it. Where can you take those results as a place to continue the conversation around learning about therapeutically informed models? And I would argue that there are three places where we start the conversation in a good spot. The first is feasibility. We did what we sent out to do. We wanted to build a CBT-informed stochastic model that captured trajectory. And we showed that you can do that. If you have the right data set, and even if you have the wrong data set, you can build something that kind of sort of looks pretty good. And you can learn stuff from it. The next thing is, we see from these data that the consequence from prior events, that kind of like feedback loop, is informative. It's at least as informative as the immediate antecedent stuff. And the third thing we see is that picking and pulling, in some sense, have trajectories which are symmetric, and we've begun to see the places where you can kind of slice them as being different. But I'm very careful to put my language in that space as within the frame of a conversation. If we say stuff too strongly using observational data, it can undermine the sense of trust that the clinical community has in those kinds of methods. And preserving that trust is really what's most important to me. What I would hope we can frame together is that we're at least with this kind of modeling, where we are thinking about the underlying machinery of therapy, the underlying kind of elements of CBT, beginning to ask the right kinds of questions of these data that lead us to bite-sized, clinically relevant, meaningfully interpretable kinds of results. And with that, I think we can hold a sense of optimism at the promise of where these types of conversations can go. But because this is a conversation, that means it's time for me to stop monologuing about this stuff, to open it up to you to see if you have any questions, to hopefully inspire you to approach me on the street or email me or whatever you need to do to find me and talk to me about this stuff, because I think it's really cool, and I welcome your thoughts. As we end, I just want to say, no research is done in a vacuum, and I'm very fortunate to have been supported by a lot of different folks along this pathway. So Dr. Passantini has been heavily involved with this. Dr. Mutono Dong has been heavily involved with this in terms of acquiring data, bantering with me in terms of like what thoughts go into these kinds of presentations. And I really want to kind of express my appreciation to all of them. But let me stop there, and I will welcome all of you to weigh in.
Let me have just a couple of comments, Trevor, and then we'll open it up for questions. And we can stay a few minutes past 10 if people are interested in doing that. And you did acknowledge Dr. Suzanne Mouton Odom from Houston, who was the founder of Stop Polling and Stop Picking, and provided these data and has been working with you on this project. BFRBs, skin picking and hair pulling disorders, are collectively as common, if not more common than OCD, as common, if not more common than Tourette's and other tic disorders. So we kind of think of these as kind of the throwaway disorders, as an afterthought. But they are, these disorders are incredibly consequential for sufferers, and in terms of cumulative impact, probably rival that potentially of OCD and Tourette. So the fact that you're bringing attention to this class of disorders is really important, and I think more needs to be done to increase awareness. Very common, but they are easy to hide, and I think that's one reason that they don't go noticed as often. And they are talking to people with these disorders, and we work with them in our clinic, and in other ways, it really can be debilitating. So this is really exciting work. The other exciting aspect is bringing big data to these data sets. This is an amazing data set about 5,000 patients, and I forgot exactly how many actual picking, pulling incidents. I know it's in the tens of thousands. So the ability to work with a data set like this is pretty incredible. And this was just first pass. I mean, I think as you alluded to, there's a lot more hidden in these 20 to 50,000 picking and pulling incidents that I think can really increase, add value to what we understand. The prior consequences, I think the finding here is really interesting. And it really speaks to the learning, I think, associated with these behavioral disorders such as this. And the way that BFRBs differ from OCD and Tourette's is that the actual act, while rife with negative consequences, is actually pleasurable. Unlike doing a compulsion, you feel better because you make something bad go away, but you're not necessarily enjoying doing it. It's a sense of relief. Picking and pulling can be actually pleasurable events. So the prior episodes and the gain from engaging in these behaviors, also through relief of emotional distress or other fun activities, uncomfortable sensory experiences, really is powerful. And these data show that it really drives these behaviors. So when we're doing treatments with habit reversal, in the moment treatments, we really need to think a little bit more about how we can address some of these forces, historical forces, either near or long-term historical forces, how they're driving these behaviors, and maybe think a little bit more. And one of the ways of doing that, at least with adults and adolescents, is much more attention being paid to augmentation with acceptance and commitment therapy, or DBT, or other types of factors. So I think these data are really valuable. I'm excited to see what else comes out. Very briefly, I just want to talk about another initiative from the TLC Foundation, and that is the BFRB Precision Medicine Initiative. And this was funded by members and donors from the TLC Foundation to fund 3 sites. UCLA, we were here. It was Tara, Paris, Emily Ricketts, myself, and Joseph O'Neill. Mass General, Harvard, and University of Chicago, led by John Grant. Nancy Cuthet and Darren Doherty were from Mass General. And this was a large study. We studied 332 individuals aged 11 to 65 and matched controls with neuroimaging, neurocognition, genetics, and extensive phenotyping to see if we could develop some biologically based or phenomenologically based and biologically validated subtypes so we can better focus our treatment efforts, and trying to identify based on things like response inhibition, reward seeking, emotion regulation. These are all factors that are very common and we think are important here. And we have made some progress in identifying some of these subtypes, and doing couple studies now have shown that there's some neurologic validation. We're also looking at other factors like response inhibition. Emily Rickards just has a paper published on kids with BFRBs. So it's a rich data set. If people are interested, there are opportunities to work with this data set. And the reason I'm bringing this up is because I think that Trevor, the work with the big data is just an amazing complement to this. So on one hand, we're trying to examine the biological substrates. We're trying to identify the environmental factors so we can try to develop some more homogeneous subtypes that we can target intervention. But ultimately, it's going to come down to, I think, this behavioral and event by event understanding of what's going on, because we're looking for the home run. We don't have medications for this. And hopefully the BPMI will help identify some possible compounds that might be helpful. But I think it really is going to be most important to come down, how can we behaviorally, cognitively, working with other factors, individualized treatment to address these, what is most relevant for patients. And there are differences. You saw some of those scatter plots and those big data figures that you showed. There's a lot going on, and we have a lot more to learn. So I am just so excited about this work, and it's just so impressive, the work that you've been able to do, Trevor. So thank you for that from the community, the BFRB.org community. I suggest you all go to the website and learn more about these disorders. We do have a few minutes for questions, and let me open this up and see what we have. From Jim McCracken, really cool and exciting. In thinking about other applications equally complex, like understanding therapy process for anxiety with anxious kids, therapist satisfaction, symptom change, treatment fidelity, outcome, how many cases would you need per variable to attempt a credible analysis similar to your example?
I love it, Dr. McCracken. It's a wonderful question. I'm going to give a very wishy-washy answer, which is depends. It depends on how much granularity we can capture per person over time. We think about big data as being all these variables and all these observations that exist, a kind of gigantic matrix that comes out. But some of the best big data answers and questions that come up are often with really small studies where there are things that we can learn from a big data perspective using small observations. So if you have only a handful of people, but you have a really big model that you want to fit, you can consider the kind of a sense of like big missingness in those kinds of situations. And there's a lot of stuff that's been written outside of psychiatry in terms of taking really high quality small studies and thinking about them from the big data perspective. So what I would say is, as small as you want, we can still learn something. And especially if it's small, but really, really well characterized, there's a wealth of richness that you can kind of think about in that space.
Great. And the corollary to that is, Trevor, before you graduate, can you help us in COC develop the individualized tracking system we need to start collecting this data? And in a couple of years, we may have something to play with.
Perfect. That sounds great. We'll get started on it right now.
Great. We have time for a couple more questions. Can you speak a little more about how you'd use causal inference methods in a project like this?
Awesome. So I think thinking about causal inference, which is a branch of statistics that is very in vogue right now, and is kind of in many ways, so it's not the part that I've directly trained in, but it is part that's kind of immediately amenable to the kind of methods we use here. So causal inference methods that you might have heard about are things like propensity score matching, using kind of structured equation modeling type stuff. And the nice thing about working with a regression framework is, as soon as you put things in terms of regression, you can think about how you would integrate those kinds of models so that it is generalizable to causal inference methods. And I would argue that especially once you're thinking about penalized regression, things like propensity scores and propensity score matching follows directly. So from a mathematical perspective, being able to extrapolate from where we are in terms of our methods to something where there's kind of direct causal inference that's happening is pretty computationally slick. We can do that.
Cool. And are there other data sources that might be used to augment or expand on these analyses?
That's yes. And, you know, Dr. Passantini, like to echo your comment about like all the new tools that are coming out right now, it would be lovely to have data that are able to capture what people are doing directly. So if you have an app and then people are logging in and you have that combined with like wearable electronics and you're seeing that the behavior, that there's a fidelity between the behavior you're capturing from these kind of reports and what you're capturing from the wearable electronics, you can gain a lot of power in terms of what you're observing. Kind of to echo back to Dr. McCracken's even question with that.
Right. I think that's all the time that we have. So I just really a fantastic, what a unique presentation. I learned a lot. There's a lot I didn't understand that I need to learn more about. But just this was really fantastic, and you opened a window, I think a really exciting window for me anyway, and I think for a lot of us about new ways of approaching data and what we can learn from some of the data sets that might be out there that can augment more of our traditional types of research endeavors. And I think the BFRB community would be very happy to know about this talk because, again, it's a disorder that is oftentimes ignored. There's so much stigma associated with these individuals and their symptoms and their appearance that you know, there's a lot of work that needs to be done. And I think this is a really important part of continuing to spur this work. So thank you very much.
Thank you for having me.
Thank you, everyone.
Bye, everybody.